Hello, everyone. Welcome to the RF AMD podcast. And today we have a special guest from Italy, Naples, Italy, Dr. Stefano Spiezia. Dr. Spiezia, welcome.
Thank you. Nice to meet you all.
Great to see you again. Last time I saw you was in Naples in your office.
Yes,
So,
my office is the Ruish Clinic. Yes,
and,
where
and
I
in
offered
a
you a
beautiful view.
yes, I offered you a very good coffee. I remember.
Boy, the coffee was fantastic. It was a macchiato with two
Yes,
shots of espresso.
yes,
And we had a beautiful view of the coastline from your office.
yes. The Gulf of Naples, Capri, Sorrento. Yes, all the
Yeah,
coast.
so amazing. Really beautiful. And it's really great to have you here today to
Thank you. My pleasure.
talk, talk
Thank you.
about thyroid ablation. We're just going to work through a lot of common questions that patients have. But before we do,
Yes.
Dr. Spiezia, tell us a little bit about why you became a doctor and why do you do what you do? When did it start? Were you like 8 years old and you said, Mom, Dad, I want to be a doctor? Or how did it happen?
Oh, it's very interesting question because originally I decided to become an engineer, not a doctor, because I really was quite afraid by blood. So I thought never to be a doctor. But along the years, completing all my studies, I understood that something was changing in my mind and the need to give an help to people suffering from pathologies. So I slowly started to know people in the hospital, to attend some wards, some places, to understand what will be in my future the real and most exciting way to give an help to people. And so I explore a lot of specialties, starting from cardiology to cardiosurgery, thoracic surgery, and I decided to become a general surgeon when I started my fellowship after the having been graduated. From moving from general surgery to endocrine surgery was very easy for me because I met my first teacher, Professor Zarrilli, that is a name was unfortunately has passed 2 years ago. He was an eminent endocrine surgeon in Italy. He started in the 70s the knowledge about endocrine surgery, doing it in a very safe, what I name safe surgery. I learned from him. He was a very good teacher. Then when I got my fellowship and my specialty in general surgery, I moved to Paris, where I met Professor Blondeau, that was a cardiothoracic surgeon, but very skilled in neck surgery. And he introduced me all the tips and tricks about thyroid surgery. But contemporary, we are talking about the first years of the 80s. In Europe, ultrasound was introduced as a very interesting tool, a diagnostic tool to explore all the organs. And I had this great opportunity to start in Strasbourg, always in Europe, in France, to attend the first interventional ultrasound school in Europe. And so started contemporary my career as a surgeon and as an ultrasound examiner. So the two topics of my life, of my professional lives, worked together all my life. And I started them together. There is no possibility to separate them in my professional activity, because everything I do with surgery or other practice in my professional activity is doing use, but also my mind is always thinking how to solve a problem using ultrasound if I cannot do surgery. So this is my starting point for my professional activity.
Wow. And what kind of engineer were you going to be?
I thought to be informatic engineer. Yes, informatic engineer.
Interesting. And like you, I'm not
I don't
fond of
know.
blood.
I don't know if it was better to do the surgeon or the engineer, but I think that my way now is difficult to be changed. Okay.
Okay. And since you've been doing surgery, how many surgeries on the thyroid would you estimate you have done?
I think more than 12,000 in
12,000.
my,
Wow.
yes.
Okay.
Consider,
So
consider
pause for,
that I have about 42 years
okay.
doing surgery. So
Very important. Very, very important, I think, for people listening that they understand that you are first a surgeon, 12,000 surgeries on the thyroid. And this topic of the interview is saying no to thyroid surgery
yeah.
and treating with ablation instead. So let's start with this question about thyroid ablation. What kind of thyroid diseases can be treated with thyroid ablation?
Well, if we look at the international guidelines, they say that we can perform thermal ablation when we have compressive, symptomatic, or causing aesthetic discomfort to patient. So benign, compressive, aesthetical discomfort are the main indication for these pathologies. Now, the international guidelines enlarged the indication also to the cancer, but we have some limitation that we can talk about later about the selection of the patient. I think that regarding this very important question you did before, that the most important topic beside the safety, because safety is the most important thing to observe during this procedure. The most important thing before this is the selection, the right indication. So all the goiters, multinodular goiters with compressive, because obviously you have to choose pathologies causing symptoms, because if the patient has no symptoms, when I relate to the symptoms, it means also about aesthetical discomfort. This is a symptom because the patient is not able to rely with himself or with the other people because the lump in the neck. So when the people are symptomatic, you can treat by thermal ablation. Symptomatic for compression, okay, there is no limit to the volume of the nodules to be treated because some years ago, international guidelines put a limit to the volume up to 3 centimeters. Now it's not true because we can also treat very big nodules because we can split the treatment, or we can have some technologies, different technology from the past, like microwave, that are able to be more effective on the solid compact nodules or with very large nodules because they are faster and delivering also slower energy, less energy, so they are quite safe to treat these very big nodules.
Dr. Spiezia, so let's list it out really quick for the patients listening. Goiter, thyroid cancer, metastasis. What are all the different diseases that we can treat with ablation now? Boom, boom, boom.
Yes, really. Benign multinodular goiter, autonomous functioning thyroid nodules, up to 12, 15 milliliter in one session, they could be treated with recovery of the function of the thyroid also. We can treat tumors, cancers, up to 1.3 centimeter, even if there are some ongoing trials for treating nodules up to 2 centimeter maximum diameter. Lymph node metastasis in the neck, mainly in patients that were previously already operated, so they refuse surgery. And also on recurrences, there are a lot of patients that after surgery develop at an ultrasound examination during the follow-up the presence of recurrences of the previous treatment. So they can be really operated with a very big, not operated, sorry, treated by thermal ablation, very good results. And also there is all the chapter of the parathyroid nodules. I think that the best indication for treating parathyroids are the inferior parathyroids because they are quite far from the nerve, from the laryngeal nerve. So in order to avoid complication, also doing a very good hydrodissection, so separated the nodule, the adenoma from the laryngeal nerve, we can offer the patient a very good alternative to surgery without any scar, any general anesthesia, and so on.
Awesome. And I think we keep hearing about how thyroid ablation is being used to treat even more dynamic cases. Give us one example you've heard in the last month or two where you're absolutely impressed that ablation could be used to treat a specific disease that kind of surprised you.
I think that nothing can surprise me now because I have a very large series of nodules treated. I think that the most impressive cases are those with patients with very large goiter that are no more more able to swallow, to breathe, and that after a single session, reducing the volume of the goiter of 50% at 1 to 3 months, they call me, "Hey doctor, nice, very nice, everything, because now I can eat spaghetti without having any difficulty to swallowing, or I can breathe during the night without pillows or under my shoulder because everything is so nice." So this is a case from a patient. It's a very interesting story that the patient can tell me to understand that I'm doing something very useful for them. They are happy. They are very happy because they avoid the surgery, avoid general anesthesia, avoid to have a scar in the neck, a lot of things, and that they recover very fast, everything without surgery. When no doctors formally told them, okay, you can have this opportunity.
Yeah, as a matter of fact, some doctors tell that same patient, we have to do a surgery. And then they find someone like you and they realize they don't need to have surgery.
Yes, many of them. Yeah,
okay,
sure.
Listen, the name of this book is called Say No to Thyroid Surgery. What does that mean to you? What does it mean to you, say no to thyroid surgery?
But also save your thyroid. That is my logo. No thyroid surgery or save your thyroid. I think that this is the most specific way to approach to the problem. You can save your thyroid. Yes, what does it mean? No surgery means that, okay, you don't have any kind of surgery, but save your thyroid is more important because you save a very important organ, a very important endocrine gland in your body that is the, how can I say, the organ that is able to establish all the rules about the metabolism regarding the heart, the vessels, the muscle, the brain, also for psychology. Okay, all is related in a very complicated network. What we still now, we don't know everything. So when we remove the gland, something happens that we cannot recover anymore.
Dr. Spiezia, you're absolutely right, because I had an unnecessary surgery performed on me.
Yes.
And life changes. When you don't have a thyroid, it changes. And
Yes,
And it's
change
important, I
everything.
think, for all patients who are listening to this and doctors
Yes,
too.
even if you treat the patient with the levothyroxine therapy all the life, but you don't recover everything. There's something that you lose removing the gland. So we need, when possible, because I'm not saying that surgery is not useful or is unnecessary. Surgery is necessary when the right indication are present for the patient. But without any indication for surgery, we can move to thermal ablation, or if the patient refuses thermal ablation, to go to surgery. Because mainly the patient has the right to decide what will be the right treatment, but only after that you have explained that there are some other options, not that there is only surgery. Okay.
So on that note, listen, you're a surgeon. You've done thousands of thyroid surgeries, but listen, um, why do you offer thyroid ablation? Because there's a lot of surgeons who do not offer it.
But they do not offer because they don't do this. Okay, so even if they are aware about this option, maybe they are jealous to lose something, and so they don't advertise patient about this option. But when I meet these colleagues and I explain that it's very important now to start a training program, we are doing this in Brazil, for example. We are starting to create a school dedicated to surgeons to understand the meaning of this thermal ablation process, starting from the ultrasound examination through the fine needle aspiration biopsy to the thermal ablation procedure. It's very important for surgeons to understand this also because the surgeons are clinicians that take care of the patient from the start, from the diagnosis to the treatment. So it's very important for them. So we are starting now to create this school, the Save Your Thyroid School, in order to understand all the process. When the surgeon understands that, we can treat all the patients that we see because, okay, there are some patients that refuse surgery. I can treat them with thermal ablation, for example. Or another option that is very important for us, like in my case, because I'm the head of the endocrine surgery department in my hospital, and we are an oncological referral center in my region in Italy. This means that I have a very long waiting list for benign pathologies. They can wait also 2 years, 2 years and a half to be operated because we are mainly focused on the oncological pathologies. Okay, when I call this patient, it's okay to have surgery. You need to wait about 2 years. But what's your problem? Well, doctor, I have a very large nodule. I cannot swallow so bad. Okay, no problem. Your nodule is benign. I can treat you with thermal ablation. You have to wait only 6 months, no more, no longer. So it's best for you to do this if you want. I don't want to oblige you to do thermal ablation or surgery. 100% of them decide to move from surgery to thermal ablation. This is the same thing that happened when, for example, you know that all over the world there is the program named active surveillance. Active surveillance for microcarcinoma, papillary microcarcinoma of thyroid, means that you observe your thyroid microcarcinoma for years, trying to understand if this could develop, could enlarge in the volume or could develop a metastasis, and then decide to treat by surgery. But we can do something different because all the patients that I see in my hospital or in my private activity, asking them, what do you want to do? We have 3 options. You have a microcarcinoma. It's a very indolent pathology with a very good prognosis. You can decide to have surgery removing half thyroid gland, to have active surveillance, that means only to observe you during the time, or have thermal ablation, where I destroy your cancer. And then we will do the same program of the active surveillance, but after remove the problem. Okay? All the patient, 100%, decide to have thermal ablation for microcarcinoma.
Fantastic. Okay, listen. You mentioned Brazil. What are some of the general world trends in regard to thyroid ablation?
The trend is save your thyroid is the most important trend word that we can diffuse, that we can spread to let people understand that is very important, not only to solve the problem, but mainly to save a very important organ in our metabolism, in our body. This is the most important thing that we have to, that people should understand. There is no need for removal when we can treat without an aggressive treatment. Consider also that, for example, when we are talking about having surgery, differently from the past, we don't propose the patient to have total thyroidectomy. If possible, and if we need to do surgery, we propose to have hemithyroidectomy. So remove only the lobe with pathologies, with the pathology, and not removing all the gland. Because if you save the other lobe, you reduce all the effects of the removal of the gland, as I told you before. And you don't need to have the replacement therapy or the lifelong, or only need to have a very small dose of thyroxine, levothyroxine, all your life. So this is very important to understand.
As you're speaking, one thing that stands out to me is there are some surgeons in the world that actually minimize the effect of removing a thyroid. They tell a patient, don't worry about it. We'll take it out, you take a pill, and you're good. Whereas what I hear you saying is the opposite. You're actually not minimizing it. You're saying that, in fact, if you don't save your thyroid, it's going to lead to more problems. That's fantastic. With that being said, which countries in the world are the most pioneering in regard to thyroid ablation? The leaders, the most innovative?
I think that we started in 1996 to do the first cases of thyroid ablation by laser, and we published in the first year of 2000, the first paper in the most important journals like Radiology, Thyroid, Our Experience. And when I presented my first cases in the RSNA in Chicago, that was one of the most important radiological congress in the world, in 2000, I was there contemporary with another doctor from Korea, Dr. Kim, that presented his own experience. So very strangely, in the same year, two doctors from two different countries, from Korea and from Italy, Europe, presented the same technology to treat the thyroid nodus. So these two countries were the pioneer for the treatment of thyroid nodules, and I started with Professor Claudio Pacella in Albano Laziale in Italy. He was one of the pioneers of the laser treatment, not only for thyroid, but mainly for liver. And we started together to treat patients with thyroid. So this was the start, where from this then started all the ablation. I think that now Korea and Europe are the most important and skilled countries where thermal ablation are performed, because we have treated a lot of cases. Consider that only in Italy, we had more than 30, I think also 40 centers with the skilled operator. When I say skilled operator, I say that there are operators that are practicing thermal ablation since 2005, for example, 2006, with a very large number of patients treated, and with a very well done learning curve and training, because this is the other aspect. Okay, I told you before about the indication. The other aspect I want to talk is about safety, because there is no thermal ablation without safety, without a very accurate learning curve and training to do this. Because I'm quite concerned now about a lot of trainers posting on social media about their experience that is lasted only about 2 years ago, started only 2 years ago, with very few cases treated. Now they became trainers. Okay, you can be trainer, but I want to see what will be the learning curve of your trainees, because it's very important to understand if you are a very good operator. This is a very big difference from the operator with the trainer. The trainer is a doctor with a very deep experience treating, that has seen a lot of cases, but also very skilled in manage complication. Because another most important topic of thermal ablation is reduce the number of complications. Because when we compare with surgery, you know, surgery, even if it's done in a very good center with a lot of cases, with a high volume of people treated or patient treated, is not avoided by complication. Unfortunately, it's bound with some complication, and some complication regarding the voice change, the pulse of the vocal cord, the hemorrhage, the hypoparathyroidism, that with thermal ablation never will happen. Hypoparathyroidism, for example, or hypothyroidism. I think that actually Korea and Italy or Europe are the most advanced and were pioneer in the treatment of thyroid thermal ablation.
Yeah, you mentioned Italy and Korea, and I think what's important for patients to take away from that is you said the year like 2006. The thyroid ablation, you've been practicing it for 20 years,
Yeah,
whereas in some countries have not even begun. So if you go to the UK, just now there's a couple doctors that are starting to practice. I think it's important for patients to know it's been going on for 20 years.
Yes, more than 20 years, because we started in 1996 with the laser ablation. Yeah.
Yeah, so it's been around a long time. Okay, here we go. You have everyone's attention. You know, you're talking about saving your thyroid, avoiding thyroid surgery. What are the complications? What are the risks?
About thermal ablation, do you mean? Yes. We have very few complications. Never of them are life-threatening. But consider that even if they are very rare, they could be severe, because we act in a very small anatomical region, very rich of important vital organs. So first of all, the most important complication is the voice change. Most of the voice changes are temporary. Very rarely they are definitive. Palsy of the vocal cord. It may happen that we can have a voice change, a temporary voice change that recover completely after 2 hours. It's very important to manage with some technologies, with some techniques, to avoid that a temporary complication could become a definitive complication. Then we have the nodule ruptures. This is a very not good complication, because we have the rupture of the capsule of the thyroid gland and all the material, the colliquation of the nodules that we have previously treated, exit from the capsule, occupying the subcutaneous space. So the patient experiences a very large mass in the neck that is very painful, and the patient is very concerned about this. We don't need to treat. We don't need to insist. We don't need to do to give the patient antibiotics, because it's not an infection. It's only colliquation of the nodule after the procedure, and doing maybe to some microbleeding inside. Then we can have hematoma. It's very common when we have very high vascularized nodule, if you press with the gauze on the neck and apply an ice pack on the neck, will stop completely also the hematoma and the hemorrhage. There are some complications very rare, like the Horner syndrome and others, or maybe also skin burning when we treat nodules that are very superficial. There are some tips and tricks to apply during the procedure that the trainer, the operator must be very skilled to perform in order to avoid this complication. So this complication can be very, very few in your experience if you are able to understand before starting what you have to do to the patient, what you have to perform from the anesthesia to the hydrodissection to achieve the best result.
Well, let's compare it to thyroid surgery. Ablation compared to thyroid surgery, which one has a higher risk?
Surgery is higher risk than thermal ablation. And there are some complications that never will happen with thermal ablation, such as hypoparathyroidism, because we don't remove, not removing the gland, we don't get the risk to remove also the parathyroid gland. We only treat the nodule in the thyroid. Okay, so we don't remove also all the tissue that is around the gland.
Let's pretend you treat a patient with thyroid ablation and the treatment is not successful. What is the next step?
May happen that we can have unsuccessful treatment. What does it mean, unsuccessful treatment? Because some cases don't achieve a shrinkage more than 40%, for example, in 6 months. This means that the treatment is not successful. So you have to perform an ultrasound evaluation, very accurate ultrasound evaluation, understanding if there is some problem or related to the procedure, for example, that was not well done, or because you have vital tissue very well vascularized with some areas not revealed before that you have to study with fine needle aspiration biopsies. I have a very few cases because if your indication were precise before doing thermal ablation, also the result will be achieved very, very quickly and in the best way. So you have to stop.
Listen,
you have to stop your follow-up, doing another fine needle aspiration biopsy, and decide also to proceed with a new session, or decide if the fine needle aspiration is not satisfying to perform surgery. But very, very few cases.
There's probably some people listening to this, and you got their attention. They were thinking they had to get surgery. Now they're hearing you talk, and they're thinking, maybe I don't have to have surgery. So how do I find a doctor? You give us, the veteran in thyroid ablation, you are the veteran. How does a patient screen for, because not all thyroid ablation doctors are equal, correct? How does a patient locate the right doctor to treat their thyroid ablation?
I think that they could ask the doctor about his experience, how long he performed from when he started to do this, how many cases, how was his learning curve, how many complications and what kind of complication he had in his experience, because it's very important, because I give an informed consent to the patient. I don't perform thermal ablation without explaining everything, mainly on the procedure, on the complication, and also about my experience. How many voice change I had, how many, for example, hematomas or hemorrhage I had in my past experience. Is important because the people are affording this new world of thermal ablation should be aware about all the turn around the thermal ablation process.
But Dr. Spiezia, if you're watching what's going on in the world right now in regard to thyroid ablation, it's a big buzz in the healthcare community, and it seems like there's a training every day around the world.
Yeah.
Why would I go get trained by you when I could just go get trained by, I don't know, another doctor?
Because if the patients are really about my experience, my story, my personal story, and also they know that I offer a lot of training classes all over the world. Maybe that my experience, my skill is what they are looking for to have a treatment performed by me.
Mm.
I think that a very good doctor in this field should be a doctor that can offer the patient all the option, and the patient
Mm.
you can take the patient with your hand,
Mm.
okay, and let him to decide not what you want that he decide, but that he can decide. But the patient can decide only when he's aware about all the options. I can tell you,
Yeah.
okay, this is surgery, this is thermal ablation, this is percutaneous ethanol injection, this is doing nothing. For example, there are some cases where the patient asking me to have thermal ablation for a very small nodule. I know that actually this is a very important business to do thermal ablation.
Mm.
It's not for
Mm-hmm.
me, because if you are not symptomatic, if you don't have
Mm.
a aesthetical discomfort, I don't treat you. So please do
Mm.
nothing. Wait 2 years, 2 years, it will become too larger all the time
Mm.
during the time. Okay, we will treat. Now there is no need. Okay, but there will be a lot of doctors doing the same. Okay, or
Yeah,
not all the same.
I think the part that you said was really important there is that if a patient is seeing a doctor that offers multiple treatment options and not only surgery, but also ablation,
Yeah.
that's a good starting point. Now, there's still a lot of surgeons around the world who are skeptical of thyroid ablation. What do you tell a doctor who just is skeptical of thyroid ablation and is determined to continue only surgery for the thyroid?
Yes, I think that in order to abandon their skepticism, it's important that is what I say to my colleagues. Please come to my center and look to the treatment and look for my cases and understand if we can offer to your patient the same options, because uh, in your center, in your activity, you can offer only surgery. But you have a lot of patients that you lose every day because, for example, they have a very high comorbidity for general anesthesia. You cannot treat them, but they are not malignant for thyroid cancer. They are not with the very important contraindication to be treated with thermal ablation. So why don't offer to this patient this opportunity? You can gain and not lose this patient. Not only you can reduce your waiting list because, for example, as in my center, I have a lot of oncological patients. So the benign goiters will be operated in 2 years or more. If you have a very long waiting list, you can offer the patient the thermal ablation procedure in order to be operated, sorry for the term, operated, but treated by thermal ablation very soon, 6 months at maximum. Okay, so this
You
is a very
know,
good opportunity not to lose patient, not
yeah.
to gain more patient. When they understand this, okay, they move to thermal ablation.
Hmm. Hmm. Yeah, I think it's so important for a patient listening that my thought is I'm going to have more confidence if I am told by the doctor that there's options. I would locate a doctor that not only offers surgery but offers thyroid ablation. On that note, there seems to be two most common types of thyroid ablation: RFA, radio frequency, or MWA, microwave. Can you give us kind of the 60-second summary about the difference between RFA and MWA and why one or the other would be used? to treat certain cases?
Yes, this is a very good question because both are very effective on treating nodules. Radiofrequency is very effective on nodules up to 30 milliliter of volume, spongiform, that means mixed fluid and solid nodule, but is mainly affected by the sink effect. In other words, when the nodule is very high vascularized, it's less effective. Microwave works with a different kind of energy deriving from an electromagnetical field, not from electrical field, and is more effective in treating solid compact nodules. It's obviously very effective on spongiform on the other nodules, but when we have solid compact nodules, microwave, in my experience, is more effective. And is able also to treat very large nodules. So larger than 30 milliliter, we can also treat in one session 50, 60, 70 milliliter, because we can have the option of some different technologies with thicker needles to introduce in the gland to create very large area of necrosis that is very effective to reduce very quickly all the volume of the gland, even if it's very large. So these two techniques are effective, both effective, but there are some differences, mainly regarding the structure when it's solid or the volume. I prefer microwave.
Okay, as we kind of wind down here for your interview, few more questions, kind of what I would say, kind of a rapid fire, quick answers. And here's the first question. Which thyroid ablation case that you treated are you most proud of?
Sorry, which case of thyroid ablation?
Yeah. Of all the cases you treated. And by the way, how many thyroid ablations have you done?
I've done about 6,000, 7,000 thyroid ablation.
6,000? Okay, so 6,000 or 7,000. It might be difficult to choose one, but is there one that really stands out that you're most proud of?
Most proud, yes, a case of a very recent case I treated with the women that seems to me very, very old women, but really was 50, 54, 55 from the anographical point of view, but since 70 years older or more, with a very large goiter. Well, I decided to treat after a very long conversation with the patient about the need to do this. She refused surgery completely, and I offered this option. She was not skeptic because she was aware about this option, about this possibility. She studied everything very well, and I decided after this conversation to start with 3 sessions because it was a bilateral multinodular goiter, very large. And after the 3rd session, when she came at the 3rd month follow-up to my private office, I met a different woman, younger. She was brilliant in her face, was happy, very small nodule, not so bigger like I saw before, and all the personality, all the aspect of the lady completely changed. For me, this was the most important thing that I achieved in my professional activity, because I saw a patient changing, completely become a very happy person.
Really transformative.
Yeah,
transformative.
Really.
Wow. You know, how about this? Have you ever had a patient walk in your office and say, Doc, I went to a doctor already. I already know I need surgery. And then you say, guess what? You don't need surgery.
So to refuse a thermal ablation when the patient...
No. Meaning the patient already went to another doctor.
Yes.
That doctor said, you have to have surgery.
Okay.
And then the patient came to see you and you said, no. You don't need surgery.
Okay,
Has that
yeah,
happened?
it's yeah, it's common. Every day it happened that people come to my office or my hospital to understand, to receive a different option, because all the endocrinologists, for example, or other surgeons recommend to have a surgeon to refuse thermal ablation. I don't want to convince my patient. I want only to let them understand everything about the different options. So I put on the table everything. Surgery with the result of surgery, because it's a definitive treatment. We cannot go back when we have removed the gland, okay? With very high risk for complication if they will done in a not good center for thyroid surgery, that not always we will solve all the problems, because removing the gland, the patient don't resolve some problems related to the metabolism, to the a lot of things. They need to get a long life treatment to replace the removal of the gland, and they will have a scar in the neck. Then on the other side, we have a thermal ablation treatment, no scar, no general anesthesia, because the recovery after the treatment is immediate. You can go back at home very quickly and recover very fast and go back to your activity, to your family, to your job, no problem. No scar, no general anesthesia, local anesthesia, but mainly you don't lose, you don't miss your gland. So you completely save your function. This is very important. What we do, doctor? We do the most important thing, that is to remove your symptom. So thermal ablation is not like a surgery. It's only
No.
a reduction of the mass, okay? It's a cytoreduction, not more than this. When the people
Fantastic. And
understand this,
you said the key thing: save your thyroid. And Dr. Spiezia, as we kind of wrap up the final couple minutes here, just a few more short questions, and that is, if a patient comes to see you for thyroid ablation, how much does it cost? Average.
the average cost in Italy, if we speak about the treatment in private activity, is about 4,000 euros, including everything from the procedure to the devices to the admission in the clinic, and everything, okay? In the national health system, the reimbursement from insurances or from the national health system, for example, is about 3,500 euros. So it's quite similar to the private activities.
Next question. Is there a question about thyroid ablation that you wish people would ask you?
What's the importance to save my thyroid gland? When I explain everything about this, they all decide to, if they can, to receive a thermal ablation procedure and not the surgery. Because no other doctors explain to people really what means to save the thyroid.
Dr. Spiezia, thank you.
Yeah.
You had some wise words for patients who are going through the journey. Maybe they've been told they have a thyroid nodule. Maybe they're told they need surgery. Maybe they're told they have thyroid cancer and have to have surgery. And it's really thanks to you. It's thanks to doctors like you that are allowing patients to save their thyroid and say no to surgery and have a different treatment option that preserves their quality of life.
Yeah. Thank you. Thank you for giving me this opportunity to explain my activity, to explain my meaning, mind, and to give the patient all the opportunity that I can offer them.
Thank you, Dr. Spiezia. Have
You're
a
welcome.
great day.
See you next time. See you next time. Bye.